Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to continue the dental pharmacology lecture with Pharmacokinetics, the Principles of Pharmacology 1, created by Dr. Kannan Shah, presented by me, Rishi Shah. The table of contents for today is Principles of Pharmacology, the Roots of Drug Administration, the Overview of Pharmacokinetics, and then the four concepts of absorption, distribution, metabolism, and elimination. This is what we call as ADME concepts. ADME. The next lecture will be on dynamics. Okay, moving on. Let's compare the two pharmacology principles. First of all, it's kinetics, and the other is dynamics. What's kinetics? It's what the body does to the drug. When the drug moves through the body, what does the body do to the drug? Remember, kinetics, in other words, means to move. So when the drug moves to the body, what will the body do to the drug? And then pharmacodynamics is what drug does to the body. So D for D, drug right here, and then what it does to the body. Okay, so this lecture is on kinetics, so we'll focus on this side of the slide. We're going to talk about four major concepts, very important in basic pharmacology. Absorption, distribution, metabolism, also known as biotransformation, and elimination and excretion. Absorption has routes of drug administration and drug transport. Basically, how does it get to the blood? And then distribution is when from the blood it leaves, or what happens of the drug in the blood. So affinity, the plasma protein binding in the blood, the bioavailability, how much drug gets to the blood itself, and then volume of distribution and where it gets distributed from the blood to which tissues. All of that is under distribution. Extremely important concepts, guys, so get your notes out and let's go ahead. Metabolism and biotransformation, we got phase 1 and phase 2 hepatic metabolism. What does the microsomal enzyme activity have to do with the biotransformation? Basically, these are liver enzymes. And then we'll talk about therapeutic index and steady state kinetics as well, also important concepts. And renal elimination. So as we can see, this entire lecture is extremely important, you guys, and all the concepts will follow us all throughout pharmacology. Okay, let's take a look at this side over here, the drug at the site of administration. Now, before we begin, I just want to tell you guys there's two things, right? We got enteral and we got parenteral. Both of them are biggest rivals of them all, because enteral, such as oral, and parenteral, such as IV, have two different routes to begin with. Oral will get into absorption first and then move through the ADME. However, IV will skip absorption and only will have the distribution, metabolism, and elimination. So very important to remember that, guys. Okay, parenteral, enteral, inhalational, transdermal, and topical. So enteral is number one, the drug that will pass through the oral and rectal route and pass through the GI tract itself. So we got oral and we got rectal. Next is parenteral, the drugs that will bypass the GI, introduced into the blood directly via intravascular or indirectly via intramuscular and subcutaneous. So we got all three routes here. Inhalational, very, very important. Drugs will pass through the respiratory tract and as delivered as aerosols, right here, inhalation, such as drugs that treat asthma. Transdermal, basically anything that is attached to the skin will pass through the underlying tissue, lead to the blood, the systemic circulation. Remember, blood is important. Transdermal will end in blood in form of patches, right here. And topical is similar to transdermal, as it will pass through the skin locally, but not end up in the blood. Not in the blood. That is such as sprays, cream, lotions, topical, right here. Let's break them down one by one. We know that oral route is the most acceptable, however, still the most unpredictable route, right? It goes through so many stages. It goes through the entire GI system, then to the liver, and then to the tissues or kidneys for excretion. There's so many stages Even though it's the most convenient route, it is still the least effective route because of this concept. Remember though, high surface area of small intestine provides high absorption, specifically in the area of duodenum. Drugs will pass through the first pass hepatic metabolism. We'll talk about this in the future. It's got a low bioavailability. Basically, when 100% of the drug is introduced into the mouth via oral route, only about 15% of it gets into the blood. The rest is used or wasted, and therefore it has a slow onset of action. It takes about 30 minutes. It's actually the longest amongst all the other routes. It's not indicated for emergencies for the same purpose. Side effects are nausea and vomiting. Rectal route, it's low and irregular absorption. You can't really predict it, and it's got slow onset of action just like oral. It's got poor patient, sorry, I apologize here, it's patient acceptance. Now, people really would prefer to have it oral rather than rectal, and acceptable for unresponsive and unconscious patients. In that case, we can opt for rectal. Acceptable for patients that have upset GI as well, so that they can't take any medications through the oral route. Next is intravenous, IV, is parenteral route, number 1. It's got the highest bioavailability, 100%, directly into the blood, no exceptions whatsoever. Emergency, hospital procedures. We know that IV drips, direct injections are ideal for emergency situations. Most rapid response. However, it is still a reversible and irretrievable mode of administration. Remember that oral, if you took any drugs through oral, we can induce vomit, and now we have the drug out, right? However, in IV, once it goes into blood, that's it. There is no other out. It's the fastest onset. It's immediate, almost 1 minute to the maximum. Direct transport to the bloodstream, unlimited amount, but limited concentration. What does that mean? You can put even a liter of drug into the body. However, it's the concentration that determines the effect. So we must be limited by concentration, not limited by volume. It bypasses the GI route. Therefore, it has no absorption. So in the ADME, there is no A. It's only DME. Side effects such as phlebitis, that's the inflammation of the veins when you inject, local skin irritation, and potential anaphylaxis. Intramuscular route, most common route of parenteral drug administration in dentistry. Now, why do we say that? Is because instead of doing IV, we may just inject the muscle because the onset is still very fast, right? It's still 5 minutes faster than oral. It's slower, however, than IV. We know that because IV is almost just less than 1 minute. We also need to know that when the IM drugs are delivered through aqueous solutions, it's a faster absorption than any drug that is oil-based solution, which has a slower absorption. So important point here. In adults, we use deltoids and buttocks with 1 inch of depth. In children, we use anterior thighs, a 1/4 inch depth. Also important points here. The maximum penetration of 2/3 of the needle length only. This chart here shows midazolam as a drug of example that lets us know plasma concentration. We got in intramuscular to reach the 5 milligram peak, right? It goes up there. It will take about 20 minutes, as it says, in plasma, right? Peak plasma, 20 minutes. However, in IV, for it to reach, it might just take about 5 minutes. So that shows us how different IV and IM can work. Subcutaneous, also a parenteral route, right? It goes under the skin. It's slower onset than IM and IV with a 15-minute. However, it's still faster than oral. The route allows a peak plasma level at 30 to 90 minutes. Right? So for example, in this chart, if we were to put SC, it would look something like this. It would go here and then like that. So at 30 to 90 minutes right here, we have SC, peak plasma level. In the side note, I would like to mention here that the onset of action is dependent on two main factors. One is vascularity, and this other is nature of drug. So vascularity means wherever there is a high capillary or high blood flow, you'll see a higher absorption and distribution of the drug, such as if you give a drug IV, intramuscular, subcutaneous, or even inhalational, because lungs also have a high blood supply. And the nature of the drug matters a lot too. Like for example, if two drugs are still IV, they could be absorbed at different paces, right? IV epinephrine is still faster than IV amoxicillin. Or a subcutaneous nitroglycerin is still faster than an IV of steroid. So imagine that. We've so far considered IV as the top-notch, the best and the fastest. However, in this case, if you're delivering nitroglycerin, a subcutaneous route may be better. So for example, here there's two injections that are shown. The subcutaneous injection is right above the muscle, where intramuscular injection is all the way down into the muscle, right? Right here, that's the muscle, and that's the subcutaneous. So the depth is what matters. In the respiratory routes, we got inhalational. We just mentioned that high vascularity of the lung allows for a fast absorption, faster onset than subcutaneous and oral, because it only takes 5 minutes for inhalation to start working. And it's similar to intramuscular route because of the 5 minutes. And then we have the transdermal. Transdermal's got a patch delivery system, right? For example, this patch right here. It's got a bunch of layers like clear backing, drug reservoir, drug release membrane, and contact adhesive. The drug diffusing from reservoir into subcutaneous tissue. At the end of the day, the yellow particles of the drug will end up in subcutaneous tissue where the blood vessels lie. However, it's different from the others because it is sustained release delivery system. The drug delivered via patches on the skin over a long duration of 12 to 24 continuous hours. The drug is steadily delivered into the bloodstream. The onset is very similar to, subcutaneous at 15 minutes, and peak plasma level is the same as subcutaneous at 30 to 90 minutes. Okay, let's talk about the actual concept of absorption, the drug transport. What is absorption to begin with? It's the process of drug from the site of administration to move into the blood itself. This is absorption. Only IV has 100% bioavailability. All other routes provide partial absorption only. After absorption, the drug must cross biologic membranes to reach target organs for transport. Now, I just want to make one thing clear here, that biologic membranes are made up of fat. Plain and simple, fat. In other words, it's called phospholipid bilayer. Now, why is this term so important? We'll figure it out in just a minute. See, and if the target organ is liver, right, then large fenestrations such as these slit junctions will allow the drug to move between the blood and the interstitium in the liver. This is the basement membrane, the yellow one. That is the phospholipid bilayer, the fat, right? And these are the inside of the capillaries with the endothelial cells. The drug will move through between the slits in target organs such as liver. However, in the brain, we must have two perfectly designed systems for drug to move from the blood vessel into the brain itself. What does that mean? Well, number one, we must have a lipid-soluble drug for a drug to enter the brain. And second, carrier-mediated transport should be present, which allows the drug to transport into the brain. Why is that? Well, a lipid-soluble drug will definitely be soluble through the phospholipid bilayer, or carrier-mediated transport that may use energy or another protein to pull the drug from the vessel and drag it across the membrane into the brain. That's what absorption is about, guys. Now, what types of factors can affect absorption? We got drug formulation. Liquids are faster than solid form for absorption. Drug concentration, of course, higher is faster. For characteristics, lipid-soluble drugs and non-ionized drugs are faster. Now we did talk a little bit about the lipid-soluble, but what is non-ionized and why is it faster? We'll talk about that in the future slides. Drug administration. While IV, IM, inhalational will always be faster than subcutaneous and then faster than oral, right? Cell membranes. Permeable capillaries are faster than semi-permeable. So liver absorbs faster than brain does. And then vascularity, obviously higher is faster. Okay, so the two rules that we pull out of this slide is lipid soluble is faster absorption and non-ionized, which means a drug that is not charged, is faster into the tissues, right? We want them to go into the tissues. Okay, various types of drug transports. We got simple diffusion, which is also known as passive transport. Simple diffusion is passive transport. Basically, lipid-soluble and non-ionized drugs are easily transported. The drug will travel from high to low concentration, and drugs with molecular weight of less than 60,000 will be easily transported. Basically, it'll go through the slit junctions that we were talking about earlier. Facilitated diffusion is specialized transport. The drugs that will transport through the channels. Carrier proteins aid the transport. So this is facilitated by carrier proteins. Right? They have specific, specialized channels that the drug will travel through. And then comes the active transport. It is a specialized transport as well. However, this one is active. It uses energy to allow the drugs to transport. The carrier proteins are 100% mandatory in this. They need a taxi to go through. The drugs can travel against the concentration gradient, where it can definitely move from low concentration to high concentration instead of the other way around. So it says here that the drug administered orally are first exposed to the liver and may be extensively metabolized before reaching to the rest of the body, right? So for example, you took it oral, you went down there, and now you went into the stomach and out the portal, hepatic portal circulation into the liver, back into the portal circulation into the heart and other systemic circulations and other target organs. Or if the drug administered is IV, it enters directly into the bloodstream, into the systemic circulation, and have a direct access to the rest of the body. So direct blood and then into the systemic circulation. Okay, here's a chart that explains what we just talked about. Passive diffusion of a water-soluble drug through an aqueous channel or pore. So if this drug is water-soluble, blue is for water-soluble, it passes through anything that's got pores or any aqueous channels. The drug will move into the cell. However, passive diffusion of a lipid-soluble drug must dissolve through the membrane, because this membrane is phospholipid bilayer. This should dissolve through the membrane. Now imagine if there were no pores at all, then we must have a drug that is lipid-soluble. Therefore, we can conclude that lipid-soluble drugs have a higher absorption. They do not need channels. They can pass right through the membrane as they dissolve through the phospholipid bilayer. However, in facilitated diffusion, the drug is now connected to a drug transporter. This is the taxi. The drug sits on it, and then it pukes it out into the cell using facilitation. And then comes active transport, one stage up from the facilitated. We have the drug that sits on the drug transporter, correct. However, it needs to use an ATP in order to flip the entrance and bring the drug inside the cell. That's active transport. Moving on to the second concept for today, distribution. We're going to talk about affinity, plasma protein binding, bioavailability, and volume of distribution. What is distribution? Let's begin with that. It is the reversible nature of transport of drug from the bloodstream into interstitial fluids, the target organs and non-target organs, and enterohepatic circulation for metabolism. Again, remember, this is reversible. This is the most important factor of pharmacokinetics. Most important. We mentioned that earlier. Distribution is number one. IV route of drug administration bypasses this phase as well. It doesn't need help to distribute itself. It's going to go directly to the target organs from the bloodstream itself. What affects distribution? What are the factors? We also mentioned that vascularity and the rate of blood flow is very important, right? Well, specifically to the target organs and tissues becomes the most important factor because that blood carries the drug. Now, what about plasma protein binding? I will correct it here. Plasma protein binding capacity. It determines the duration of action. Now, what is that concept? It is albumin, which is the plasma protein, that binds the drugs and makes them inactive. And then release from albumin will make them active. What does that tell us? Well, think of albumin as a taxi. For example, you're leaving your home to get to work. You can only start working if you leave your bus, right? Now, if you left the home and went on the bus and sat there, but the bus driver never stopped, it just kept going and going and going, you could never get to work and never start work. Therefore, you must get off the bus, walk to your work, get absorbed into the target tissue, and be active. Therefore, the bus is albumin. I hope that explains the plasma protein capacity. And it determines the duration of action because the longer the bus ride, the longer the duration of the action. Because once the drug becomes released from the albumin compounds, it's going to get active. So it's either going to get active in the next 5 minutes or it's going to get off the bus in the next 20 minutes. That now becomes an increase in duration of action. Okay, drug affinity to tissues. That will determine the concentration. What does the word affinity mean? Affinity means the attractiveness, the magnetism, right? If a drug is highly attracted to a receptor, then it's going to sit on it and tightly bind to it. How tight it binds to it. Now, if it loosely binds to it, then it won't give proper responses. But if it tightly binds to it, then it will give immediate and appropriate full response. That will determine the concentration, right? If it's low affinity, we want high concentration because we want a tight receptor and drug interaction. And then gastric emptying, one of the least important factors of distribution. So this picture here explains the whole bus concept. This is the compound and that's the plasma protein. That's the yellow thing is our bus, right? Plasma protein containing compartment. The drug sits on it. This is an inactive drug. This is an active drug. All of these drugs are waiting to cross the blood-brain barrier or the liver portal membranes or any sort of blood membrane in order to get to the transport tissues. So when it gets into the blood, it might catch albumin and sit there. So plasma protein capacity, higher it is, higher the duration. Bioavailability, here it is. It is how much drug is active after it reaches the bloodstream. So 100% of the drug is given orally, and only about 15% reaches the bloodstream. So oral drugs have a low bioavailability. Gastric acid, liver metabolism will be the ones that will reduce this bioavailability. And then there's the other counter side where a direct IV administration will have an increased bioavailability. Next important concept is volume of distribution. Volume of fluid into which drug is dispersed upon distribution. Well, what does that mean? Well, our body has a lot of fluid, right? Interstitial, intracellular, extracellular. Our body is made up of water, we say, right? 70%. Well, the drug must be dispersed into that fluid upon distribution. That's volume of distribution. So what's the formula? It is total amount of drug So total drug divided by plasma concentration of the drug. So plasma concentration of the drug. That's our volume of distribution. However much total drug amount we have divided by how much it's concentrated into the blood. For example, if blood concentration is low, so if this is low and volume of distribution is high, then the drug was found to penetrate target tissues, right? If, for example, the concentration was low, but still the volume of distribution is high, that just means that the drug went into the target tissue. We want it out of the blood. Blood to tissue. If the volume of distribution was high, then everything from the blood went into the tissues, and now it's all into the tissue and blood concentration is low. This is ideal. This is goal. This is what we want for any drug that is manufactured. We want low blood concentration remaining, high target tissue penetration, and that's what we call high volume of distribution. Okay, pictorial description. Bioavailability, basically area under the curve of oral, area under the curve IV times by 100. Remember, bioavailability is measured in percentage. So this is a picture where the drug is being administered into orally, and plasma concentration of the drug is measured on the y-axis, time is on the x-axis. So when the drug is administered by oral route, it cannot reach as much plasma concentration because it has to pass through the GI, it has to pass through liver and metabolize and so on, right? So the concentration will always be low. However, in IV, the concentration begins at like 100% and then it reduces as time goes from the blood. Therefore, to measure bioavailability, our formula is oral over IV times 100. That's the formula for bioavailability. This is to describe the volume of distribution. See, our total body water is consisted of plasma, interstitial volume, and intracellular volume. We got 42 liters basically. And in intracellular volume, it's 28 liters of cells. However, extracellular, which is your plasma and interstitial, it consists of 14 liters, out of which interstitial volume is only 10 liters and plasma volume is 4 liters. So we want every piece of that drug to move from here into here. And that is volume of distribution. And now let's move on to metabolism and biotransformation. We're going to talk about phase 1, phase 2, hepatic metabolism, liver. Basically, this is the concentration of all liver. The whole focus is on liver. Microsomal enzymes, also in the liver. Therapeutic index and steady-state kinetics, which are very important concepts of a drug going through the body. And then elimination and excretion, which is renal. Well, that's our next topic. Okay, what is metabolism? Also referred to as biotransformation. We've been talking about it for a while. Technically, it's a mechanism of elimination. Well, think of it, right? Now, our drug is in the blood. We moved it through our tissues, and now it's leaving the tissues through the blood into the enterohepatic circulation or into the portal circulation and enter the liver. Why did it enter the liver? Well, it's entering the liver to detoxify itself and go out our body through kidneys at the end. Therefore, it's a purpose to reduce the plasma concentration, get it out of the blood, and prepare itself for urinary elimination. Well, the two main phases of hepatic biotransformation in the liver. We got phase 1 and phase 2. We got oxidation, reduction, hydrolysis, all in the first, and conjugation in the second. The purpose of the liver is ideally to convert a drug molecule to a polar and inactive form. Now this is where our previous point of non-ionized versus ionized point comes in. Remember that a drug will be active if it is lipid soluble and non-ionized. Remember that? But the function of the liver is to make it water soluble and ionized. In other words, inactive. An inactive drug will just leave the body. Therefore, our lipid-soluble drugs are great. They will pass through the biologic membranes. The non-ionized drugs will be active and affect the body. However, the liver will make it water soluble and ionized. Completely the opposite, and make it inactive. We call it polarizing the drugs. This reduced reabsorption will increase elimination. That's the purpose of metabolism. So let's take a deeper look. What is phase 1 hepatic biotransformation? The liver uses microsomal enzymes to carry out this entire phase of metabolism. Those enzymes are in the family umbrella known as cytochrome P450, which is the most common enzyme used by the liver. There are several others, right? In the family, the relative contribution of CP450, there's a lot of different ones. There's 2E1, 2C19, 2D6, 1A2, so 1 and 4. There's a lot. 3,4A. Now, if you look closely, in the entire family of P450, we got 36% of 3A, 4, and 5. Very large component. And then comes the 2D6. So these two we'll always talk about in the next few lectures about different drugs. We'll always talk about the 3A4 and 2D6. There are 3 possible outcomes of phase 1. When the drug enters the liver to be metabolized, there are 3 possible outcomes of phase 1. One, an active drug will turn into inactive. We just talked about that. The other is the active drug will turn into active 2.0 and then to inactive. This 2.0 is known as metabolite, the production of metabolism, such as diazepam turning into oxazepam is still active. Codeine turning into morphine, still active. Meperidine turning into normeperidine, still active. And then at the end, it will inactivate itself in the further processes of biotransformation. The third outcome is an inactive drug will turn into active. Now this is opposite, right? Such as pepsin will activate other drugs. So in the presence of pepsin, the liver will make sure that inactive drugs will become active. What is phase 1 hepatic biotransformation? Again, there are 3 possible reactions of phase 1. We just looked at 3 outcomes. Now we're going to take a look at the reactions: oxidation, reduction, and hydrolysis. In oxidation, we subtract an electron to make a drug polar. Remember, ionized, inactive, and this is the most common mechanism. We just subtract an electron. And in reduction, we add an electron, still making the drug polar, but this time we add an electron. Hydrolysis is a physical breakdown of molecular bonds. Moving on to phase 2 hepatic biotransformation. The products of phase 1 will pass through phase 2. This will come across conjugation reaction. That will take place in the second phase. The purpose of this phase is to convert the metabolites, or a whole drug, into inactive polar molecules and allow for ease of elimination. Remember some drugs that had active to active 2.0? Well, they have to enter phase 2, the metabolites, and then become inactive. There are 3 possible conjugation reactions of phase 2. We got acetylation, we got glucuronidation, which is the most common, where glucuronic acid coupled with drug metabolites to make them ionized and polar. That's what happens. A glucuronic acid will couple itself with the drug metabolite and then it will become inactive. And last but not the least, it's the sulfation reaction. Okay, let's move on to the actual enzymes that conduct this entire procedure of biotransformation. Microsomal enzyme inhibition And microsomal enzyme induction is a very important concept to learn because it's in drug-drug interaction. It's in several other drugs such as antibiotics. We got antifungals, antivirals, analgesics. It's everywhere. So it's important to learn this. So what is microsomal enzyme inhibition? Remember, these enzymes will metabolize, right? These will conduct the metabolism. So the inhibition means low metabolism and high blood concentration. Remember, the purpose of the liver and its enzymes was to reduce the drug from the blood and get it ready for elimination. However, if you inhibit the enzymes, well, then it will be low metabolism and the drug will pile up in the blood. Microsomal enzyme induction is the exact opposite. You want to hype up these enzymes, hyping up the metabolism, and that leads to low blood concentration of the drug. Remember, there are several groups of drugs that inhibit the enzyme and several groups of drugs that will induce the enzyme. We'll take a look at that in just a second. Plasma protein binding, here it comes again. Higher the binding, lower the metabolism. Remember, the drug must leave the bus in order to enter the tissue and then through metabolism and so on. But if the plasma protein binding is higher, then the metabolism will be lower because the drug is not free, still on the bus, due to the lack of free drugs available to enter the enterohepatic circulation. Situations where there is liver diseases, old age, and genetic predispositions, biotransformation is affected. Chronic alcoholism will act as enzyme induction. It will increase the other drugs that you take with the alcohol to have a faster metabolism. So what does that mean? When there is an induction, the drug's duration of action reduces. When there is an inhibition, the duration of action increases, right? Remember, more drug will pile up in the blood if there is inhibition. Therefore, the duration of action increases. When drug is leaving the blood and then not piling up in the blood, we have reduced duration of action. That's what microsomal enzymes are for. Okay, let's break that concept down even further. Microsomal enzyme inhibition, lack of polar conversion of drugs. Remember, inhibition of metabolism. Metabolism equals making drugs polar. Therefore, inactive. But inhibition will prevent that. Lack of polar drug conversion. This process prevents the drugs from being eliminated. Therefore, the drug is not polarized enough. Therefore, plasma concentration of the drug increases, and therefore drug activity prolongs. This is the concept for increasing in duration. I hope we're just following around, guys. I hope the concept is clear. We're trying to elaborate it as much as possible. The drugs that are CYP450 inhibitors, such as external grapefruit juice, alcohol in acute doses, not chronic alcoholism, acute dose of alcohol, erythromycin, cimetidine, ketoconazole, acyclovir. Remember, these are antiviral. This is antifungal. This is antibiotics, right? All the drugs, all of these are inhibitors. Therefore, in the presence of these drugs, the drugs will remain active excessively. These drugs work to increase the effects of other drugs around it. Basically, if you took erythromycin with another drug, erythromycin will inhibit the metabolism of the other drug, leading to increase in activity of this other drug. And that's where drug interaction video comes into play. So we have added it in the comments below. Please go ahead and take a look at the drug interaction video if you haven't yet. Next is induction. Induction is the excess of polar conversion of the drugs. This process accelerates the elimination. Therefore, the drug is polarized even faster than intended. Therefore, the plasma concentration will decrease and the drug activity is then hindered. So, which are inducers? We got barbiturates, smoking as a habit, chronic alcoholism, carbamazepine, phenytoin sodium, and rifampin are all drugs which will induce metabolism of other drugs. So in the presence of these drugs, other drugs will become inactive even faster. It'll be biotransformed faster. These drugs work to decrease the effects of other drugs around it. Again, go ahead and see the drug interaction video, guys. It is explained very well in that video with examples. Here are just some pictures of other drugs that belong to various subgroups. Remember, we said 3,4-A and 2D6 are important. So then we got other drugs such as carbamazepine, erythromycin, nifedipine, verapamil, cyclosporin. All of that is a part of common substrates that get metabolized by 3A4. And then inducers of that are carbamazepine and phenytoin and rifampin and so on and forth. So this chart is not extremely important, but I just put it in there for your reference. The last two concepts of metabolism includes therapeutic index and steady state kinetics. So let's talk about therapeutic index. It is a ratio. To begin with, it's a ratio. It is LD50 divided by ED50. L is lethal, E is effective, 50 means 50% of the population. So LD50, lethal dose at which 50% of the subjects show lethal toxicity or death from the drug, a specific dose. And ED50 is the effective dose, a specific dose at which 50% of the subjects will show therapeutic or intended effects and will respond well to the therapy. So our goal is what? Our goal is to have a high therapeutic index ratio. A high TI means low fatality. Basically, if LD50 was 5 and ED50 was 2, then our therapeutic index ratio was 2.5, right? Which means a drug with a variation of 2.5 on each side of the spectrum will either lead to effective or lethal effects. We want this to be more so a 12. Or even better, we want it to be more so 25, where LD is at all the way at 50 dose and ED is only within the 2 dose. So the overdosage ratio, the window has increased. What is NTI? Narrow therapeutic index. A high risk of clinical toxicity is NTI. When a therapeutic index is less than or equal to 2, then we're looking at a very toxic, which means if you take one more pill than recommended, which is 2, then we're dead. We don't want that. We want to be able to take 100 more pills before we die, which increases the overdose ratio. I hope that explains the concept. Here's an example. Warfarin has a small therapeutic index, which means that the desired therapeutic effects will begin at this concentration here, and unwanted adverse effects will begin here. So the window that we have is very narrow. The distance between the therapeutic effects and the unwanted effects is very narrow. However, in penicillin, we got a large therapeutic index, a large therapeutic window as well. Desired effects are here, however, unwanted effects are all the way here. We got a huge window of opportunity here. So if you took like twice as much penicillin, then you won't have that much problem. But if you took twice as much of warfarin, now we're looking at easily unwanted adverse effects. So that's therapeutic index. Therapeutic window concept is a range. It's not a ratio, it's a range, which is between the lower value of TI and the higher value of TI. What does that mean? Well, lower value is the desired effects beginning, right? At this point, the therapeutic window begins, where the effects are starting to show. However, the higher value is the adverse effects starting, which is here. This is where adverse effects start. So this becomes our window. This is where we want our drugs to be. And wider the therapeutic window, safer the drug, right? If this window was all the way this much in width, then it's a safer drug than this drug itself. So remember, the TI or TW are measures of safety. Okay, what is steady state kinetics? Very important, guys. Let's just start with the basic first. What is dosing? It is the process of administration of drug in a period of time aimed to achieve therapeutic levels. That's our goal, right? Drug given over a time period. What is steady state kinetics, however? This statement is extremely important. I'll start it over here. If I put this in red, it would be even better. It is when the quantity of the drug eliminated will equal the quantity of the drug that reached the systemic circulation. That is steady state kinetics. It is when a drug accumulates and then plateaus in the plasma. It is determined by half-life. Well, you say, what is half-life? It is actually the amount of time required for a drug to be eliminated from the circulation by half its volume. So when a drug reaches blood and then it gets eliminated, how much time does it take to get rid of 50% of it? That's T half-life. Now theoretically, to get rid of the entire drug away, eliminated from plasma, we want to go through 5 half-lives. It can take up to 30 or 3.3 half-lives. I apologize, it's 3.3 half-lives for a drug to be eliminated 90% clinically. So this is very important. A drug must travel through 3.3 half-lives of itself in order to be eliminated 90%. 5 half-lives, theoretically, of course, to be eliminated completely from the plasma. Well, what does that mean? Well, for example, we started off with 100% drug, right? What's half of that? 50%. So that's your first T half. What's half of this? 25%. Your second T half. This is 12.5%. This is your third T half. Moving on, 6.25%. This is your fourth T half, and now you keep on going, right? How much could you reach? Well, effectively, you can't really get rid of the whole drug entirely. That's why we said theoretically. But up to 1, 2, 3, and just about here is 3.3, which is about 9.9% of the drug remaining in the body. Well, it's 90% eliminated. That's the concept of T half-life. So here it is. 50% of steady state drug concentration is achieved at T half-life. Right? At T half, 50% of the drug is now in circulation. That's where the start of infusion is. Right here, you've infused it, and the drug infusion has stopped here and washout begins. So as soon as you stop giving the drug in, the washout begins. Okay. 90% of steady state drug concentration is achieved by 3.3 half-life. Right here, this is 3.3. 90% of the concentration has been achieved now. Okay. Here, the washout of the drug is exponential with the same time constant as during drug infusion. For example, the drug concentration declines 50% of the steady state level in 1 T half-life. So right here, in first T half-life, 50% reduced. So 1 T half-life also means 50% reaching the plasma concentration, and 1 T half-life also means 50% washed out. 2 T half-life means further drug has been washed out and eliminated, and at 3.3, 90% of the drug has been washed out. So remember, 3.3 is a very important number when it comes to T half-life. That's the point of the whole concept, guys. Okay. So steady state kinetics has 2 types of orders through which drug is metabolized. We got a 0 order and we got a first order. What is 0 order? Well, zero order is when a constant amount of drug is being eliminated per unit time. So every 5 minutes, we're getting rid of 5 milligrams of drug. That is constant amount of drug. That is zero order kinetics, such as alcohol. First order kinetics, this is where most of the drugs fall, is when a constant percentage of drug is being eliminated per unit time, proportionally to the drug concentration. Percentage, amount. Here are the diagrams that help us explain it. So I'll use this diagram here. With a few drugs such as aspirin, ethanol, which is alcohol, phenytoin, the doses are very large, right? Huge doses. Therefore, the plasma drug concentration is much greater than the Km. And the drug metabolism is zero order. That is constant and independent of drug dose. It'll just keep going away from the body as much as you put it in. However, with most drugs, the plasma concentration is less than Km, and the drug elimination is first order. That is proportional to the drug dose. So this chart explains to us that the rate of drug metabolism from 0 to 100 is shown in a very linear manner, and that's your first order, right? It's going up like that. However, when the drug is being eliminated or metabolized, the dose of the drug is independent. It doesn't matter how you're increasing the dose. This will just go on its own as you enter. Okay. Last but not the least, the elimination and excretion. The route of excretion. Kidneys are primary, we know that. That's the route. Followed by the liver. Yes, the liver also excretes drugs. It is a process of elimination of drugs and metabolites itself, physically itself, from the body after being metabolized or being used by the tissues. The formula for renal excretion. Now this is a very important formula, guys. The rate of renal elimination equals elimination plus filtration minus reabsorption. So E is elimination or tubular secretion to be specific, filtration by glomerulus specifically, and reabsorption by tubular action itself. This formula will determine how fast something leaves your body. There are rules though, rules for renal excretion. Remember, only polar, water-soluble, ionized metabolites are filtered easily. Remember, we keep repeating this point for the same reason that we always lodge in our mind that polarity and solubility are very important when it comes to the whole pharmacokinetics. Next, plasma protein bound drugs or lipid soluble drugs or non-ionized drugs are all reabsorbed back in because they're going to stay in the blood longer because of plasma protein. They will not be eliminated. And these lipid soluble non-ionized will be active. They're not inactive drugs. They're active. Active drugs will affect tissues. They have to become inactive for them to be eliminated. So these are the rules. We know that there's free drug that enters the glomerulus filtration system, Bowman's capsule, right here. It has to pass through proximal tubule. This is where active secretion of the drug happens from the body into the proximal tubule. It leaves through it into a narrow loop of Henle. It ideally looks like this, right? Ascending loop, descending loop. In the loop of Henle, there's not much action here. However, in the distal tubule, distal convoluted tubule, that's where passive reabsorption of lipid soluble, unionized, so basically active drugs, which has been concentrated so that the intraluminal concentration is greater than that of the perivascular space. This entire clause, all it means is basically moves through this gradient. And then the collecting duct will then just eliminate the ionized, the lipid insoluble, also known as water soluble, into the urine, and it leaves our body. That's elimination. So, breaking it down, what is tubular secretion? Using active transport, the drug molecules are eliminated. That's this, tubular secretion. What is glomerular filtration? Well, free drugs are delivered from the blood through the nephron, right here. It enters the Bowman capsule. Okay, terrible arrow, you guys. Please don't follow that arrow. I will redraw that arrow. That's really weird. Okay. There we go. This is glomerular filtration. Free drugs. Free drugs are known as water soluble. I keep repeating this point, guys, because it's important. I know it's boring. You guys have done great in the entire lecture, but I know it's boring, but very important. Water soluble and ionized or polar drugs are free drugs that are delivered from the blood through the nephron. And then what is tubular reabsorption? Lipid soluble and non-polar drugs are taken back into the blood. Non-polar also mean non-ionized. Now, this is important here in the magnification glass here. Passive reabsorption of lipid soluble and unionized drugs from the distal tubule will then lead to phase 1 and phase 2 metabolism, and then ionized or polar metabolites, right? So it gets reabsorbed, and then the drug gets into the metabolism, and then it becomes polar and metabolite after its second life, after reabsorption, and then it gets eliminated. So that's very important here. Other minor routes of elimination are the GI tract, such as nystatin excreting from feces. Nystatin is the antifungal. Salivary glands are really not true elimination. The lungs, however, they have volatile drugs that excrete them. And sweat, negligible excretion. But they're still a part of it, right? The rate of elimination again, E plus F minus R. Very important formula. Okay guys, I know today's lecture was very long, but very important. It's the foundation of pharmacology. We picked it up from Lippincott and Little and Fallis. The links are in the description box below. I hope you guys learned something new today again, and please follow for more academic lectures like this one, and the next lecture is pharmacodynamics, so stay tuned guys. Thank you so much. Have a great day.